Good afternoon, everyone. Thanks for joining our Asian Hour or bi-monthly webinar series, where we feature topics on eHealth, health information systems, and information technology for civil registration and civil statistics. Today's webinar is our first webinar of the year, and we're happy to see familiar names on the list. Please feel free to invite your friends and colleagues to join the session. Our webinars are recorded via WebEx and will be made accessible online after the session on the following pages: asian.org and index.org. Before we start, here are a few reminders: the platform, how to participate, and the email feedback. We're using Cisco WebEx Event Center. If you're having troubles in joining, kindly log out of the session and rejoin through the link sent to you by WebEx or by entering our meeting room number 864-169-368-950, and password is possible TW1263. Your mic will be muted throughout the meeting, but you can send your thoughts to us through the chat tab, and for the questions, please type them in the Q&A tab. Our speakers will answer your questions after the lecture. You will also receive a survey after this session. Kindly answer it so we can send the resources of this session to you. Today we have Mr. Anna Traud, Healthcare Systems Engineer at Possible Health. He's been leading Bahmni EHR's implementation at Bayalbhata Hospital in Far West Nepal since late 2014. He has an undergraduate degree in engineering and a master's in engineering design and innovation from Northwestern University. He has been previously involved with companies like Aspira, Samsung, Procter & Gamble, and Covidien on product and service innovation projects. Mr. Anat is committed to building a durable healthcare system for Nepal using smart technology and human-centered design. Today, he will be sharing the journey in EHR at ACHAM and elaborate on integration of patient data, integration of national systems, and role in national eHealth plans. For the second part of the presentation is Mr. Ranjan Takhali, lead developer at the ThoughtWorks Family team. He has been leading various ThoughtWorks software development teams since 2006, and he was also heavily involved in the Bangladesh Shared Health Records Project, where ThoughtWorks is helping the government of Bangladesh to build a national level health record system, and is passionate about building great software products focusing on equal healthcare system for everyone. He will be presenting about Bahmni and its implementations, their experiences in Bangladesh and national health record systems, technology architecture and standards, as well as different systems like ComCare to integrate with national SHR. May we now pass on our presenter controls to our speakers.
Hi guys, can you hear me?
Yes, we can hear you well. Thank you.
Thank you. So I'll be talking today. There might be a little noise coming around me because I'm in a noisy place, but forgive me for that. Let me know if I need to repeat anything. So today I'll be talking about how we designed and deployed a national public sector electronic health record, how we did it in Acham, and our plans to roll this out in the rest of the country. Our aim is to create a digital healthcare system that is affordable for the government. And we're stressing on the affordable part because I think the government is ready to go digital, and they've shown that with how they're approaching DHIS2 and how they're like moving towards DHIS2 at a facility level. But I think the biggest concern right now is that they want something that's affordable and something that they can maintain themselves as well. And the EHR that we are using is being used for and will be used for DHIS2 reporting, which is something that we are currently trying to integrate with. It will be used for population and disease surveillance, quality improvement initiatives, and eventually national delivery science. To give you some context of where we work, so we are located in the far west rural Assam. We run a hospital, a public hospital, in a public-private partnership model. It's a 25-bed hospital that gets about 2,000 inpatients, over 2,000 inpatients per year, over 70,000 patients per year, and roughly 200 to 500 patients per day, depending on the season. And we have about 140 staff members right now here, with 5 staff physicians, 2 MD-GPs, which means MD general practitioners, one MD-GP resident, orthopedic surgeon, which is kind of important here in a hilly setting like this because we do get a lot of orthopedic cases. 1 dentist, 16 mid-level practitioners who are providers who've had 3 years of medical education, 5 staff nurses, and 11 auxiliary nurse midwives. So back in February 2015 is when we first deployed Bahmni at the hospital, and it's being used for registration, for clinical services, lab services, inpatient management, stock, billing and accounting, reporting, and tax integration. And you notice that the billing and accounting is grayed out because even though that's in Bahmni, we're not using that at our facility because our hospital is completely free. Like there's nowhere where money is exchanged with the patients. So we're not using that. However, at some point if there is a universal or a national health insurance scheme, we might integrate that into our system as well. And the back end, it's running, as most folks I think who are used to Bahmni know, it's OpenMRS, OpenERP, OpenLS, and also this DICOM, open source DICOM viewer we use for PACS called DCM4J. In terms of like how this is being used at the hospital, so when a patient comes in, they're registered in the EHR by a registration assistant, and after registration, they get a unique ID. When they go to the outpatient clinic, the provider can enter that provider number and can pull up that patient's record and starts entering data, and like lab orders can be placed with the EHR, X-ray orders can be placed with the EHR, and when these orders are made, the patient can simply go to the lab pulls up the patient's orders and like fulfills that, and also puts in the lab results in the EHR itself. Actually, the same thing, the orders are automatically created in the X-ray software, and the images are like available from the patient's record. So when the patient goes back to the outpatient clinic, the provider just pulls up the patient's record, the lab results are there, the X-ray results are there. Then the outpatient can, if the provider prescribes some medications, the patient can go to the pharmacy, where the pharmacist again pulls up the patient's record, sees what medicines have been prescribed, and dispenses them. And since it's integrated with the ERP, we are able to then know the exact amount of stock that's in the pharmacy, because as medicines are dispensed, the quantities decrease from the store. If they go to the inpatient, we also have admission and discharge, as well as bed management in the inpatient ward. And finally, outside all this is reporting component, which is done by a separate person who, like at the end of the month, collates all these reports and submits them to the government. Currently, what we have is the EHR is at the district hospital, which is Balpada Hospital. It's a single facility where we are running Bahmni. And we want to now like move on to it being a district hospital and it being used as a hub for primary clinics. So at primary clinics, they might have a computer or maybe a couple of computers that the providers at the primary clinic would be using. And a patient, if a patient is referred from the health post or the primary clinic to the hospital, the provider at the hospital can see the records of the patients that have been referred. And also, if a patient has been, chronic disease patient has been discharged from the hospital, if they just visit the health post, then the health post provider can see what was prescribed or what was done at the hospital. So there's some seamless, movement of data between these two different tiers of the healthcare system. Next, I think moving after that, we want to go to the household level, and we are right now we're working with ComCare so that we have this software on the phone that community health workers can use as they go to the household, to the patient's homes to track things like chronic diseases and maternal and child health related things. So that's something that's coming up very soon. And all of what we're doing is, again, integrated, is all within the government's health reporting system. So currently they use what is called Health Management Information System, HMIS, but working with the external development partners, they're digitizing this to another level with DHIS2, and they're rolling this out in a number of districts in Nepal very soon, and we are ready to integrate with DHIS2 as well. Now, like moving from just having it in a town where we have this at the district hospital, we'll have a hub, and also move into the community around us. Now we want to have this be an integrated national EHR. So we're kind of replicating this model in another district, like very soon. And our vision is to see multiple hubs like this throughout the country and their seamless movement of data between all of these systems. Now, like, even though, like, one of the big concerns about affordability is how expensive is this, but one of our arguments is that even paper is expensive because right now, when the way that providers use paper records in health posts or these hospitals, there's a lot of reporting that has to be done on paper, and we've seen that it can take up to like 3 days a month, which is about 10% of each health worker's time just compiling reports, and that's a lot of time and money wasted. And also, like, there's a potential loss of medical history because a lot of paper booklets that we used to give out, they're lost or they're damaged, or patients just forget to bring it in, and all that medical history is lost. And again, like if there are certain paper registries for certain programs, for example, like ART, ANC, these programs have different paper registries that the government wants us to fill out. But if they're updated, if there's a change in those paper registries, it can take months for those paper registries to make it to these rural areas. If we had a digital system, anytime a change has to be made, it can be made simultaneously in all these different areas. Then there's cost involved in printing, transportation, storage, and of course there's environmental consequences as well. Our affordability mandate, we want to create a paperless system that is affordable within the government system, and we will improve systems while saving time, paper, printing, transport, environmental costs, all the stuff that we talked about before. Some of the challenges that we've faced in implementation at Balpata, so some of it like that we will probably see in other locations as well, is the first one is the status quo bias. Like clinicians are so used to paper, so just having a different system, regardless of how good it might be or what it could do, there's this like inherent status quo bias that providers can have that prevents them from really getting that buy-in. But that's something that will go away with time. Next is infrastructure. So initially, again, we struggle with working in a remote area. We may not have constant electricity. The internet is not very good. If something goes wrong in the network system, getting new parts and everything like that is very tough. And we may having enough computers, if there's more staff added, how do you get computers here real quick? So things like that we've started to improve, but that was a challenge in the beginning. Another thing is perceived value. So that this can come from also inexperience with how they use these electronic health records. So patients, like the clinicians, a lot of times they're so used to just seeing the patients for that day. Unless they're a chronic disease patient, generally they will not look at past medical history. So they don't really know how to use the health records to not only enter data but also use it to help with clinical decision making. And all of these again lead into buy-in from providers. So once we get past that hump, then I think it'll be easy to get buy-in from providers. And next is patient health literacy. So a lot of times, here, patients also do not get why, sometimes even though they've been given a unique ID, they may not understand why they need to keep those booklets safe and bring it back again the next time. So a lot of times what happens is every time they come in, they'll just register as a new patient. that doesn't really help their medical history either, and that doesn't help the providers provide them the best care possible. In terms of the national health challenges, one of the problems that we're facing is that we give out our own IDs because it's very difficult. We don't really have a universal health ID or universal ID that is usable in that way. And this is something that we are pushing the government to come up with very soon. And another challenge will be like, how do we get government buy-in? But for that, I think as we expand to like multiple facilities, multiple places in the country, we will, and we can prove that this can be done at an affordable way and it's effective. I think we will get that buy-in. And at the moment, there is no eHealth policy, and so there was a lot of work being done to create an eHealth policy. But I think that was just before the earthquake happened, and once the earthquake happened, a lot of these plans have not materialized. And I think like it's also an opportunity because the eHealth policy is so it's still being built. We have an opportunity to prove something and get this the electronic health record system into the eHealth policy as well. So far, we have achieved about 100% EHR uses in all outpatient departments. Our lab, pharmacy, X-ray, they're all digitized. They're all integrated within the EHR. All of our government reporting happens from the EHR. We have seen an improvement in data quality, and data-driven QI initiatives have also been. This is something that we've just recently started. So how do we improve like how the kinds of discharge notes that are in patients? Are we writing clear discharge notes for patients? That was one of the QI initiatives done. Now someone else is looking at if we are providing good counseling. So that patients with COPD, for example, know how to use inhalers. And like once because we have more data and better data, we can track that over time and see what can be done to help improve that. Next is facilitating follow-up care in the community. So with the EHR, we can now get a list of like chronic disease patients that have come for follow-up or that have missed their follow-up care, and like if they've gotten good counseling, and like once we have a list of missing patients or patients that might have been lost to follow-up, we give these lists to our community health workers who can then go track them in the community and provide follow-up care or ask these patients to come back to the hospital. And also the EHR helps drive best practices because when you're writing it on paper, there's not a lot of accountability. The EHR, they're kind of forced into writing like chief complaints and treatment plans and things like that in a best practices way. Just last month, we had the Ministry of Health and one of the ADP partners, GIZ, visit our hospital just to look at the EHR, which is pretty exciting. So the government is starting to take notice, even though their focus is primarily on reporting for now. They want to have better M&E systems, which is why they're rolling out DHIS too. But this is something interesting that they're also looking at if EHR is feasible for the future. We've also helped with costing for national health insurance, and we feel that we would be able to now also integrate national health insurance within our system. And we are also helping push for a universal health ID, which is something that's an active communication right now. So next, until now, we were only in Sanford Bagar in Acham, Nepal, which is in the far west. Now we just signed an MOU with the government to actually start running an active public district hospital. And this is pretty exciting. We will be deploying the EHR in Dolaka, which we just started running that hospital a week ago probably. And now we're rolling out the EHR in the first week of March or the last week of February. Next steps, we will be deploying Dolaka. After that, even within Acham, we want to go to the district hospital and also go out into the primary clinics. And we will continue to work with the government to finalize the national EHR pilot, which will hopefully be in Acham or Dolaka. Finally, like Nepal just drafted a new constitution which says that every citizen shall have the right to primary health care and emergency services free of cost, and that's what we're going towards. And we see EHRs as being a core component of universal health coverage. And as we say in our possible rule number one, what we do, everything is to solve for the patients. Thank you.
Thank you, Mr. Anand. We will now transfer the presenter control to our second speaker, Mr. Ranjan. Hello, Mr. Ranjan.
Hello, can you hear me?
Yes, we can hear you well. Thank you.
Can you hear me now?
Yes, we can hear you.
I'm unable to hear you. Hello?
Hi, Rod. We can hear you.
Okay. Okay. So I'll carry on from where Anant left. Just to give you a brief introduction to Bahmni, simple, affordable, and scalable HR system. I've written a lot of stuff on the slides, and I'll kind of skim over some of them to keep time for Q&As. To start with, carrying over from, carrying over from where Anant left. So the focus of Bahmni is on all aspects of patient care. It's a hospital system that is simple to install and use. It's affordable, open source, works on commodity hardware, and it's scalable right from primary health care to multi-specialty hospitals to an example that I'll talk about towards the end of the presentation. We've participated in a national rollout. We are piloting right now in Bangladesh. As I mentioned, the focus is on all aspects of patient care, right from when a patient gets registered to when a clinician diagnoses, when X-rays are ordered, lab management, billing, inventory management, and reporting. Something that this slide doesn't talk about is the integration with X-rays, but I think Anant already talked about it. Moving on to implementations. Possible is one of our implementations. Anant already talked about the size. Similar in size is JSS Hospital in rural India, in a place called Ganyari in Bilaspur. It's another hospital called Search in Gadchiroli, India. Again, another remote area. There's a Banyan mental health clinic in Chennai, which is a very big city in India. A Union Health Clinic in pilot implementations for the national rollout in Kaliganj, Bangladesh. And a couple of implementations, largest implementations coming soon. One is the offline usage for community health workers in the Dhaka division of Bangladesh. And Bahmni for a large TV program for 3 global NGOs in 16 countries. So why am I talking about this? The reason that I'm talking about this is Bahmni from the ground up, we believe is built for hospitals that are in low resource settings. So what have we learned from these implementations? If you see most of these places that we have implemented Bahmni, they're all in low resource or resource constrained environments, right? So Anand's already talked about it, so I'll skim through most of these. First and foremost, we saw that there's extremely low to reasonably low computer literacy levels. We cannot depend on internet connectivity for running an EHR system. Most technical tasks require physical presence of the technical Bahmni team, and disruptions are very, very costly. They happen very, very frequently. So there's low risk appetite for hospitals to use electronic healthcare record systems. Also, service delivery context differs vastly, leading to unique data requirements. They also lead to unique uh, data collection in terms of forms, different reporting requirements. Also, not all hospitals want all the things that Bahmni provides. And so we have broadly learned and implemented Bahmni based on the aforementioned guidelines. First and foremost, the design is for resource constrained settings, which means that inside a hospital, no internet is required to run Bahmni. The second thing is Bahmni is very simple to use. We spend a lot of time learning from our users and implementers on how to make it even more easy for people to use Bahmni. It's adaptable, so you can use it on a variety of devices like tablets and computers. Various apps have tab UIs, and obviously all apps have computer UIs. It's configurable, so you could go ahead and change the basic language. You can add new language packs to make it localized to a particular area or a country. You could make location specific user interface changes like dashboard changes, form changes, report changes, and stuff. It's modular, so as you will see later, Bahmni is a combination of multiple open source tools. It's modular to the extent that you could remove some of these. So, for example, if you do not want an X-ray integration, you could just remove the PACS integration module in Bahmni and it will work. It's built for integrations. It allows others to integrate easily, and most importantly, it's written using open source software, so it's affordable and it's customizable. As I mentioned before, Bahmni is a union of some well-built OSS tools. Some of them prominent ones are listed here. So there's OpenMRS, ERP, LS, TCM4T, say Enterprise. There's a new EMR UI for OpenMRS that Corpus has built. It's open source. The reason why we've used open source software which is proven in the field is because the domain expertise that communities have built over years of development and support. These communities are vibrant and progressive, adding features. They help us immensely in building Bahmni, and obviously it's customizable open source code, which allows us to add new features and build Bahmni and add more and more integrations to help with the patient journey in the hospital. A brief overview on OpenMRS. It's a well-known open source medical record system. We use it for patient management and reference data called concept dictionary in OpenMRS. This is where all the codes sit. So diagnoses, tests, procedures, drugs, and more of these reference data sit in the OpenMRS system for Bahmni. It's basically the heart of the Bahmni system, and it has a very good, friendly, encouraging community that helps us make Bahmni better. For our billing and inventory management, we use a well-known open source resource management system called OpenERP. It's also called Odoo now. It helps us with billing and inventory management. Again, it's an extremely flexible, wide community of contributors and implementers. It's easy to get help on. We also have OpenLS, which is used for our lab management part of as the lab management component. And the Bahmni team has contributed a lot towards building new APIs to enhance OpenLS. To make it part of our implementations. We also have, as Anant mentioned, a DCM4J OVM2 integration, which is a OVM2 is a web-based ICOM viewer. This helps us to make investigation orders, which are sent to radiology devices. Bahmni also allows you to view radiology results using this component from within Bahmni UI. Right? And lastly, we have the Bahmni user interface, which is a new EMR UI for OpenMRS. As you can see, it's ported to multiple types of devices. The focus, so we built it based on our learning. So focus is on simplicity and an intuitive user interface. It's responsible. It comes pre-built with dashboards that can be customized. It comes with a library of EMR reports that can be customized. We are building offline applications for Android and Chrome devices. It's also open source. It can be locally customized. Now coming to integrations, and as I mentioned, Bahmni, as a design guideline, we've built Bahmni to be easy to integrate. So all Bahmni components communicate with each other using atom feeds over HTTP, following web standards. This means it's easy for an authorized client to listen and program based on these feeds. Each Bahmni component publishes a log of relevant events happening. So, for example, a patient gets created or a test order is commissioned. Each of these events get logged and they are published over these atom feeds. And all our components listen to feeds generated by each other and progress. So, for example, a new component, and again an example of an offline Android application where a person may, when they come online, they download all these events and then they can go offline and make and then register new events of their own. Bahmni also provides a rich data interface using the OpenMRS REST API. This means that given the right credentials, components can pull and push data directly as well. Bahmni can also be enhanced at multiple levels to add new integrations. A bunch of examples here. One of them can be to write a new OpenMRS module, which one of our teams has done here to integrate with the Bangladesh Shared Health Record System to communicate over HL7 FHR protocol. You can add custom OpenERP modules to enhance your billing and inventory management system. Adding and importing new standard definitions from standard globally recognized dictionaries directly into OpenMRS. And we've already talked about facts, so I'll move over that. Very important part of Bahmni is that it's modular. So new component, like if you have an existing lab management system, it can be plugged in, and old ones that come packaged like OpenLS can be removed. Coming to standards, in terms of medical standards, Bahmni supports various international standards like LOINC, ICD-10, SNOMED-CT. We follow the DICOM standard for communicating digital images. And since OpenMRS is not completely HL7 FHR compliant, we've built a module for OpenMRS that communicates using the standard FHR data formats with the central SHR system in Bangladesh. In terms of engineering standards, we follow standard communication protocols like HTTP REST, and we follow predictable data formats for communications based on OpenMRS. So they're not proprietary. They're not very esoteric in nature. They're all very commonly used formats. We use web standards for all of our apps. So this helps us immensely in scaling. We use the most stable and free open source operating system called CentOS 6. It's very easy to manage and can work over commodity hardware. We use free open source database engines like MySQL, Postgres. its extensibility using well-known OpenMRS ERP module systems. Coming to the national rollout for a national shared health record system for Bangladesh, I'll briefly go through what helps make a national rollout. So one of the key things is a terminology registry, where you would store country level, country specific codes. For example, ICD-10 codes localized for the country like Bangladesh, LOINC codes, SNOMED CT, and any other terminology that is specific for the country. This terminology will then drive all the work that happens on local EHR systems. Another registry that's very important is for providers or personnel. Another registry for locations. The last two are quite important. A master client index for patients, which also generates a national health ID for Bangladesh for each patient that comes in, and also a shared health record system for encounters. So data from all over the country would flow into this encounter database, and would then move on to the centralized reporting system, which is DHIS2. So there are two modes in which Bahmni works in this system. One is Bahmni on facility, which can be a primary clinic to a multi-specialty hospital. It works just like any other Bahmni or Bahmni that Anand talked about at Acham, but it does a little more. It actually comes with a new OpenMRS module that regularly syncs reference data from the aforementioned registries. Whenever a new patient is added, it sends over that data to the master client index that is centrally located. It pulls down data, and you can also download data for patients that are not part of the hospital or not registered in the hospital but are registered somewhere else. Bahmni also on the facility, it also helps with operational reports for the hospital. A very important aspect is that the sync is on demand. It doesn't need to the hospital Bahmni. It doesn't need to be online all the time. It can be online for half an hour a day and sync all the data that it requires, both push and pull of information. And lastly, there's a Bahmni offline for community health workers, which is a publicly hosted Bahmni server. So till now we've talked about Bahmni in the hospital, but this is a specific use case for Bahmni which is hosted online and targeted at health workers who are going in the community, who own communities from the health perspective. They use devices like tablet computers and bigger cell phones, and they are able to sync with Bahmni for a few minutes or hours a day, and then they go in the field where there's low or no internet connectivity, and these are built for offline usage. So they make their changes, and they come back and communicate back with the integrated SHR system when they're online. And all the data flows are the same. The system is completely integrated with the shared health record system, which is centrally located in a data center. Again, data can be pulled in for all kinds of patients who are not in the catchment for this particular CHW. Thank you.
All right, thank you, Mr. Anand and Mr. Ranjan. The floor is now open for questions. Well, the others are typing in their questions. Here is a question from Dr. Kazi. Dr. Kazi wants to know how radiological films can be sent electronically for doctor advice.
I can answer about what we do at the hospital is more. We actually have digital plates. So we use something called CareStream VDSCR scanner, like the digital scanner. And we have digital plates that can then, like, once you take actually with a traditional machine, but using a digital plate, and the digital plate is then put into a scanner. The image is then now digital, and so you can send a digital image through the PAC system.
All right, thank you. Dr. Kazi has another one. Dr. Kazi wants to know the major challenges and learning of FHR Bangladesh.
Okay, so in terms of challenges, I think I'll borrow some terminology from Anand's presentation. There's inertia in terms of moving towards a new system. That's one of the biggest challenges. It has nothing to do with software or technology. It's just that a lot of people feel that status quo works for them. The value is not seen directly in the hospital at that point in time. That's one. The other is, and in this we recognized very early in the rollout, was that having a centralized terminology registry was very, very important, because each hospital can and most probably will invest in acquiring new terminologies, and therefore reporting at a central level becomes very hard, because some hospitals might spell diabetes differently, just for an example, or they might have a different code for diabetes, and so combining and creating reports on that is very, very hard. So that's the other. In terms of again, in terms of implementing the sheer size of the country, and we've not been to more than 3 places right now. It will be huge. We've been to a couple of remote areas where we've seen that the internet connectivity is very, very low. So we're trying to build a system which can work with very low internet usage.
All right, thank you, Dr. Ranjan. We have here from Dr. Peter Morgan. It says, I'm interested in learning about any level of effort, information, person, or day. The initial setup at the hospital, ongoing operations, preparation for multi-site or national implementation. Maybe anyone on the speaker. Hello? Hello? Should I repeat the statement?
Hello?
Hello, yes, please proceed.
Yeah, so as I read the question, Dr. Morgan is interested in learning about level of effort in information person days for initial setup and ongoing operations. So I guess for ongoing operations, I'll let Anand talk about it. For initial setup, again, it depends on the size and scale of the hospital. For a 40-bed hospital that does not have much by way of existing software, it can take anywhere from 2 weeks to 6 weeks. And in the initial setup also involves our team visiting or having people having conversations and dialogue with the hospital before actually visiting and doing anything related with software, to identify the needs and use cases, designing a Bahmni implementation, training schedules, things like that. So I would say for 2 to 3 people from the ThoughtWorks implementation team, around anything upwards from 2 weeks to around 1.5 months. Again, I would let Anand talk about the ongoing costs.
Okay, at our hospital, it's a 25-bed hospital, where everyone's actually using the EHR. It's basically been me who doesn't who I'm not a networking or I'm not a developer, and another IT support person, and we've been handling ongoing efforts because once I'm used to familiar with the EHR system, I can go into the back end and do simple things like creating new templates, editing templates, doing basic troubleshooting, and the IT support person can then help with the computer, because a lot of the problems are actually simple, the internet's not working, or the internet, something's wrong with that, or the Ethernet cord is not working, the computer's not turning on. So simple IT support questions, and if you combining that the IT support with someone who has some knowledge of you can do some quick editing in OpenMRS or OpenLS, in the back end, I think that should be enough. However, we've also been working very closely with ThoughtWorks, so if there's any major issues, we do use their help desk to get their support.
All right, thank you. We have another question from Dr. Rana. It reads, how is the response of the HW itself positive? If not, are there any efforts which the team has done to tackle the negative response by the HW?
Okay, at least at Balpata, I think initially we did have some pushback, but I think one of the most important things that we did was to have what we call an EHR champion within the amongst the clinicians. So once we have someone within their team be a spokesperson or a champion for the EHR, so what we do is we have bi-weekly clinical informatics meetings where we always discuss what could be better, what what you guys are struggling with, and things like that, so that we take the feedback and actually act on it. And I think one of the most important things is if you can show them that we are actually adapting to whatever to taking the feedback and actually acting on it, they become more positive, and as we and I think it also improves the system itself. But overall, I do think having a champion within the clinical team is actually very key to deploying something like this.
All right, thank you. We have another question, and this one is from Dr. Godara of WHO India. The question is, as the EHR initiatives move towards larger scales in the two countries, what is the funding pattern that will ensure sustainability? Also, what has been the general reaction of the governments? Do they support this initiative?
I'm sorry, I couldn't get the first part of the question.
All right, I'll just repeat it. As the EHR initiatives move towards larger scales in the two countries, what is the funding pattern that will ensure sustainability? Also, what has been the general reaction of the government? Do they support this initiative?
Okay, so I can talk about our experience in Bangladesh, which has been extremely favorable. The government of Bangladesh has been very progressive. In terms of funding, we work with the government as well as funded the ThoughtWorks work is being funded by an NGO, and in terms of the response, I think we get a lot of administrative favor when we go to hospitals, to the extent that we are sometimes treated as VIPs. But yeah, I mean that also adds to a lot of responsibilities on our end, and I think the key goal that the Bangladesh government has is to be able to intelligently devise strategy using healthcare data from the ground. and they've been relentlessly moving towards that goal, and we are heavily involved with them. I think for now I have only experience with the Bangladesh teams. Anand has more data on Nepal, so if there's anything on that, Anand.
Okay, yeah, I think the experience is very different in Nepal because we're not there yet. In Nepal, a lot of it is still on paper, and we do have HMIS, which is finally the government is actually moving to DHIS too. However, I think the government's focus right now is primarily on just in reporting. So aggregated data is fine. However, I think what we are trying to say is that implementing EHR is not going to be that much more expensive, or like maybe even similar to what you guys are doing already with DHIS2. Because even with DHIS2, like they're planning on putting it at the primary clinics where you will still need computers, you will still need training for everyone, and at the end of the day, you're still using paper. And at the end of the day, you're still making the same errors that was the problem with paper, and you're still only getting aggregated data. And now with EHR, the clinicians will not have to do twice the work. You don't have to write on paper and eventually like transfer it to the computer. You use EHR as at the point of care, and it will be used to improve clinical delivery. You get very granular data, and it will really help with M&A systems, and it will also be integrated with DHIS2, which the government wants. But it's still an effort for us. It's like the government is not has not bought in yet, but we are only at one facility, and we're moving to 2 facilities now, and we think that as with time they will at least have some, they'll give in a little bit.
All right, thank you. We have another question. It's from Dr. Imperial. It reads, how much is the cost of deployment for a hospital?
Okay, so because we are doing this at a new facility very soon, I think we have some numbers, because the thing is, it did cost us a lot in the beginning for our current for Cham, because we were working with topics from to customize Bahmni for our hospital. But the thing is, with the new facility that we are deploying to, we are essentially using the same system in Cham in Doloka as well. So our costs are greatly reduced. We will essentially only be paying for I think it costs us about how much, like $30,000 for equipment and everything to set up the networking, $30,000 to $40,000, and then we will have a full-time staff to help with that. Besides that, we will probably get some support from Bahmni.
All right, thank you. We have a follow-up question from Dr. Rana. It says, for the first deployments, do you require all the HW to use only your system, or both the paper register plus your system?
Okay, again, I'm speaking from experience at Balpata, where we tried to have both systems in the beginning. We thought for a month we would use both systems, but we realized that within 2 or 3 days, clinicians were not going to use both systems. They just stopped using paper. They're like, if we're not they didn't want to duplicate their work, and there's already a lot of patients. We can't be doing both, so they just got stopped using paper. And I guess we accelerated our implementation, and they started within a week. Everyone is just using one system. Brunson, do you have anything to add here?
Hello, Dr. Ranjan. Is there anything you want to add?
Yeah. So uh, I would agree with what Anant said, that people very quickly adopt Bahmni. We've seen that happen for all of our implementations. Um, where very soon after the implementation start, another month or something, people start moving over to Bahmni. They find it more and more usable with time. Uh, we've seen in a few pages we had seen some negative responses in the sense that it was not very accessible for certain types of users. But we went and changed the user interface, and that has helped us a lot.
All right, thank you. Maybe last question. Your staff for the district hospitals, how are they trained? Are they trained on site, or are there other trainings that you do?
At here, I think initially we actually it's all the training is done on site.
So the implementation team for Bahmni uh, actually trains staff on site. Yes. I'm sorry, the audio is very intermittent.
Okay. All right, so is there anything more from the speakers? Hello? Mr. Anas, Mr. Ramdan, can you hear us?
Yes. Did you ask anything? Sorry, I didn't hear you.
So regarding the training, there was someone asking how long the training is.
Oh, how long the training is? Well, I think it's a lot of learning by doing. When we started training, like, and I think we did only like about an hour a day for a week because we're at a busy hospital and they cannot give up a lot of time for training. And and we also rolled it out very slowly. We said, the first week or so, only put in diagnosis and nothing else. And later on, like now, you can add chief complaint and maybe treatment. And it also helped that all these different modules that we're talking about were actually rolled out because when we started, there was no treatment, and these things have happened very slowly. And I think the training was pretty simple because all they had to learn to do was look up a patient, go in and add a diagnosis, or then like look up a patient, go in and add a diagnosis, then add something else. So it was all gradual. But I think just the training itself before this started was about a week, and that's it.
All right, thank you, Mr. Anas. For the last question, this one is from Dr. Samba. He's asking if do you use this system in hospital ward level, and for inpatients at ward, how is it connected with lab records?
Okay, so at Balpat, I guess we have. It's a little tough because in the inpatient department, there's still some integration to be done because right now we're focused mostly on bed management and admission and discharge.
I'm sorry, the audio is very intermittent. Could you please send a chat message for the question and I can provide
it. But yeah, so with the lab records, it works the same as OPD, like where you place an order in Bahmni and like it connects with it I think syncs with Ellis, and the lab orders show up in Ellis, and the lab technicians just fulfill the order. but maybe like Ranjan can talk to it in more technical detail.
Thank you, Mr. Anak. Since we're running out of time, maybe we should wrap up the session. Thank you for everyone who attended, especially to our speakers who shared their time with us. Please be reminded that a survey will be sent to your emails after the session. Please answer it so we can send the materials of the session to you. We also invite everyone to join our next webinar on February 4, also at 4 p.m. Manila time. It's on eHealth for the elderly. Thank you, everyone. Thank you, Mr. Ranjan and Mr. Anand.
Thank you so much.
Thank you, everyone. Bye.